This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, it's Jeff Ratliff with the Neurology Podcast and Thomas Jefferson University. I'm here with Andrew Siderowf, a movement disorder neurologist and researcher from the University of Pennsylvania. And as much as our listeners want to hear these two Philadelphia-based neurologists talk about the best cheesesteaks or speculate on the Eagles, we're actually going to talk about a study that Andrew and his colleagues published in the Lancet Neurology in May of this year, titled Assessment of Heterogeneity Among Participants in the Parkinson's Progression Markers Initiative Cohort using α-Synuclein seed amplification, a cross-sectional study. This study was a cross-sectional analysis of patients in the PPMI, as we'll abbreviate it. More specifically, Andrew and colleagues used α-Synuclein seed amplification assays to explore heterogeneity among patients in that PPMI cohort. Podcast listeners will remember that Jason Crowell spoke with Dr. Lucilla Pernetti in the August 1st, 2022 episode of the podcast about these seed amplification assays in Parkinson's. And listeners who have been listening more recently will recall that Jason Crowell had a conversation with Baz Bloom on May 11, 2023 about a 30,000-foot view of biomarker development in Parkinson's. And Jason and Baz did briefly touch on this study that Andrew and I are about to get into in a little bit more detail. We'll review some of what these seed amplification assays are with Andrew, as well as talk about how this work builds on what we already knew and some possible next steps as we talk about Parkinson's disease biomarker development. Andrew, welcome to the podcast.
Thanks, Jeff. It's a pleasure to be here.
So, Andrew, I want to cut a little bit to the chase to start us off. And my understanding is that you and your colleagues looked at cerebrospinal fluid of patients in the PPMI cohort, specifically looking at results on these α-Synuclein seed amplification assays. In that group, you were looking at both patients with diagnosed Parkinson's disease, but also prodromal or quote unquote premotor Parkinson's. You were looking at healthy controls as well as some other cohorts related to genetic causes of Parkinson's. So there's a lot going on with these various cohorts and comparisons. And so before we get into some of the details, what would you tell colleagues is the main primary take-home lesson from this project and from this paper?
If you allow me, I would say there are three take-home lessons from the paper that I'd like to emphasize. The first is that the seed amplification assay in our hands was accurately differentiated people with Parkinson's disease from healthy controls. The second point is that it identified, surprisingly, underlying heterogeneity within Parkinson patients, probably based on whether or not they had Parkinson's due to the typical α-Synuclein pathology or not. And then the third take-home is that among the non-manifesting carriers and prodromal patients we looked at, people who were at risk but didn't have Parkinson's, we found a relatively high rate of positive SAA, indicating that the pathology for Parkinson's probably has a relatively long latency period before clinical features emerge.
I think those three take-homes are important, and let's try and flesh those out a little bit as we discuss. I hope to start us off and just to refresh us a little bit, if folks haven't listened previously, about what the α-Synuclein seed amplification assay is. Can you explain what are these assays? And coming into this study, what did we already know about their role as biomarkers in the world of Parkinson's disease?
They're not really new. They've been around for at least the last 5 years, probably longer, because the same technology has been applied to identifying prion proteins in disorders like Jakob-Creutzfeldt disease. But it's an amplification technique, which is a little bit like PCR for genetic material, but rather than applying the amplification technique to genetic material, we apply it to proteins. And the technology, like I said, has been around for about 5 years and often is referred to as RT-QuIC, which stands for real-time quaking-induced conversion, and sometimes is protein misfolding cyclic amplification as PMCA. But more recently, the field has sort of coalesced around calling both of these techniques seed amplification. And the idea is that tiny amounts of self-replicating misfolded synuclein aggregates, or whatever protein it is, but in our case it's synuclein, from biological samples, and again in our case it's spinal fluid, are multiplied to reach quantities that are easily detectable by standard fluorescent measures. And what happens is that these seeds are bathed in high density of substrate. In this case, it would be α-Synuclein monomers or tetramers. And there's a self-templating aspect to the seeds so that the seeds recruit the native synuclein to form aggregates in the same misfolded pattern as the seeds. And then there's a shaking event that takes place that would mechanically disrupts the seeds, these larger aggregates, back into smaller seeds again. And then the process is repeated through cycles until there's enough misfolded protein around that it can be measured with standard analytic techniques. As I said, this has been around for about 5 years now, and a number of different labs around the world have been doing it. And the results so far have shown really high sensitivity and specificity in Parkinson patients versus healthy controls, some ability to detect alpha-synuclein in other synucleinopathies like multiple system atrophy, although this is still a work in progress, and probably the assay needs to be modified somewhat to be sensitive to MSA. And so the difference in our study is it was much larger than any of the previous studies. It allowed for analysis of subgroups and also for a much more detailed investigation of prodromal and at-risk individuals.
And so in this study, you looked at more than just patients with Parkinson's and healthy controls. And we touched on it in that first question that there was a lot of different cohorts of patients in this study. And some of those take-home points that you mentioned refer to some of the findings in prodromal Parkinson's or even Parkinson's that is not associated with synuclein pathology. And so could you outline what are the types of patients who were studied in this project and talk a little bit about how they were grouped and why you grouped them the way you did? And then hopefully we'll get into sort of some of that heterogeneity that you guys found.
There were about 1,100 participants in PPMI who gave spinal fluid samples for this study. And the largest group was people with sporadic Parkinson's disease, so Parkinson's disease, patients who didn't carry a genetic variant which is associated with Parkinson's. But in addition, there were a relatively large number of patients that had genetic variants, Parkinson's disease and genetic variants, so either the glucocerebrosidase or the LRRK2 glucine-rich repeat kinase, the most common variants of both of those genes. And there were non-manifest carriers who had both of those genes. There were prodromal individuals who had, the easiest way to think about them is they were at immediate risk for Parkinson's disease based on either having REM sleep behavior disorder, which is a clinical syndrome which puts people at very high risk, probably 5% per year risk of developing a synucleinopathy, either dementia with Lewy bodies or Parkinson's disease. And also people that had hyposmia and an unexplained loss of sense of smell. And these individuals also had positive DAT scans, so it wasn't just hyposmic individuals, but it was hyposmic individuals who, with few exceptions, also had an abnormal dopamine transporter imaging. So those are the at-risk groups, and then in addition there were two control groups. There were the healthy controls who were not known to have any neurological disorder or symptoms. They were age and sex matched with the Parkinson patients. And then there were also the so-called SWEDs, which were individuals who had clinical features that resembled Parkinson's disease at the time of enrollment, but were found to have normal dopamine transporter imaging and therefore excluded from the Parkinson cohort in PPMI. It's a large, sprawling study with a lot of subgroups. And then we just sort of drill down a little bit. So because there were Parkinson subgroups that included people with sporadic Parkinson's disease and also Parkinson's disease based on genetic variants, and then there were also Parkinson patients with a range of different clinical features. So we were able to look at heterogeneity within the Parkinson patient group. And what we found was that among the Parkinson patients that were very typical, in other words, they had not sporadic Parkinson's disease and had typical features including the typical loss of sense of smell that we see most of the time in Parkinson's disease, the test was positive over 98% of the time in this group. However, in certain subgroups, the test was positive a lot less. And this is especially true in the Parkinson patients who were LRRK2 carriers. In that group, it was about 2/3 positive, 1/3 negative. And in the sporadic Parkinson's group that had preserved sense of smell, in other words, it did not have hyposmia, and this is not the typical case, again, it was 2/3 positive, 1/3 negative. And so this was sort of the key indication that we had that there's pathological heterogeneity, especially as it pertains to hyposmia versus normosmia, and LRRK2 versus the other groups, including GBA, where we saw a very high rate of SA positivity and sporadic PD, also very high.
So as we build on the ability of these SAAs, these seed amplification assays, to differentiate Parkinson's from healthy controls, and you touched on it a little bit, these results from these cohorts tell us a little bit more about the use of these alpha-synuclein amplification assays in prodromal, Parkinson's or people with genetic mutations. And it sounds like specifically in the LRRK2 component of this cohort, the identification of α-Synuclein in this assay was not as significant. And so does that teach us something about the pathology of their Parkinson's, or does that differentiate them from those sporadic Parkinson's patients at the pathological level in some way?
That's exactly right. We think that the synuclein seed amplification assay is detecting synuclein pathology rather than a nonspecific feature of Parkinsonian syndromes like dopamine deficiency. And so we think that people that have a positive SAA have typical Lewy pathology. And we have a few patients in our study who came to postmortem, and the ones that were positive, there were about 15 of them, all had typical Lewy pathology at autopsy. We had one patient who was SAA negative, came to autopsy, and had cell loss but no Lewy pathology at postmortem. And this patient happened to be a LRRK2 positive and normosmic individual. It was a male LRRK2 carrier who was normosmic. So this is one piece of data. And then if you look sort of broadly at the literature on pathologic heterogeneity in LRRK2, the main take home is that about 2/3 of LRRK2 Parkinson's patients have Lewy pathology and 1/3 don't. And this is the statistic that's in the published literature. And this matches almost perfectly with the ratio of 2/3 to 1/3 we found with SAA positivity. And there are smaller studies that bear this out also. I think this idea that the SAA assay is detecting synuclein pathology probably needs to be confirmed in larger autopsy series, but it's very consistent with the existing evidence. So the hypothesis is that this is not necessarily a test for Parkinson's per se, but rather a test for a typical Lewy synucleinopathy.
And yeah, that's what I was going to say, sort of in hearing that you have some small groups that definitely point to a possible association between the amplification assay and the ultimate neuropathology that's found on postmortem. But I know that wasn't the primary outcome in this study that you guys are looking to study. And it sounds like further studies looking at this association between the spinal fluid amplification assays and the ultimate neuropathology on postmortem needs to be done at a larger scale to sort of explore some of this heterogeneity at the neuropathologic level as well, correct?
Yes, and we're obviously pursuing this, as patients who are in PPMI, many of them generously consented to autopsy, and then other groups are also pursuing this same line of investigation. But like I said, the data that's available, there's nothing that's inconsistent with this idea so far.
So I want to start to look ahead based on some of the findings that we've been talking about. So I want to zoom out and look at the implications of this project. And your discussion in this paper focuses on steps to come and further steps, specifically in the realm of Parkinson's research. And we touched on one of those looking at postmortem association with these assays. But in the broader scheme of developing biomarkers for Parkinson's disease, or even potentially developing disease-modifying therapies for Parkinson's disease, what do the results of this study teach us or inform us to do better going forward?
The main implication for the study currently has to do with research. We think this will be a very useful research tool for identifying people that have typical synuclein pathology who would be the best candidates to participate in trials testing anti-synuclein aggregation therapies for Parkinson's disease. I think it would benefit the participants in these trials because they'd be more likely to benefit from the intervention. It also would benefit the trials because they'd be more likely to find effects if effects are really there, because they would have a homogeneous group of participants who actually have the target pathology. So I think right now this is mostly going to be a research tool which will streamline clinical trials. It has some clinical utility now as a diagnostic, but it will mostly be for people who are very interested to understand their Parkinson's better, and it probably doesn't lead to different therapeutic decisions now. For example, the LRRK2 patients are a good example where a patient that has a LRRK2 variant and typical levodopa responsive Parkinson's would be treated the same whether or not they have an SAA with levodopa or DBS, what have you, whether or not they have synuclein pathology causing their clinical syndrome. And that's true now, but in the future, when we hope that there'll be a rational therapy that specifically targets the underlying pathology, it'll be very important to know whether patients have typical synuclein pathology or not, because you would make therapeutic decisions based on pathology rather than based on clinical symptoms.
And pivoting over to our listeners who are clinically oriented, taking care of patients with Parkinson's disease, and I would say this reflects my experience and probably yours as well, but I think it's safe to say that our patients with Parkinson's who, as a rule, tend to be very informed about what's going on in the world of Parkinson's research are going to have questions about these results and the impact on their own lives with Parkinson's. And you touched on it a little bit that these results are not going to affect our on-the-ground clinical treatment decisions. Levodopa is still going to be a primary symptomatic therapy that we're going to use. But now stepping into your role as a movement disorders clinician, can you tell us how the information and the knowledge gained from this study is affecting the conversations you have with your patients when they bring up this study or they read a press release or whatever it may be? How are you answering their questions about the clinical impact of this study?
I've been saying that this is primarily a research tool now and that it has a potential to be a diagnostic, but it probably isn't going to replace existing diagnostics, like a thorough neurologic exam, which is still the best diagnostic test for Parkinson's disease, or ancillary tests like a DAT scan. But in the future, it may. And one thing that we didn't do in our study, because it's cross-sectional, but it's possible that the SAA results provide some information about prognosis. And that a Parkinson patient that has a positive SAA, with or without a LRRK2 variant, may have a different prognosis than somebody that has a negative SAA test. And as you know from taking care of Parkinson patients, just like me, patients are really very interested to know what to expect in the future. And longitudinal studies, a follow-on from the cross-sectional study that we did, have the potential to answer whether there's prognostic information in the SAA result. And if that's the case, then we may find we do it more for patients clinically now because it will answer this really burning question that a lot of patients have.
Yeah, I think that's an important point, and I 100% agree. Patients are very interested in answers and information about what to expect over the years to come with their disease, and it can be really hard. And certainly those of us who take care of Parkinson's patients will acknowledge that, a lot of those answers are informing patients that their journey with Parkinson's is going to be unique to them, and that it's hard for us sometimes to sort of predict what will happen and when. And so if this can give us a little bit of information in that realm, I think that could be helpful as we sort of think about research studies to sort of jump off from what you and your team did here.
Yeah, I actually do want to just follow that comment up with a point about the asymptomatic at-risk individuals we followed in the study. As I said, we looked at people that had idiopathic hyposmia and also REM sleep behavior disorder. And in that, within those two groups, which we think are at relatively high immediate risk for getting Parkinson's disease, we found about 80% more or less had positive SAA results, which isn't terribly different than the rate of positivity amongst all PD comers, including the LRRK2 and the normosmic ones. But I think for these individuals, like if you were found that you had an abnormal sense of smell or were diagnosed with RBD and you wanted to know, is this something I really need to worry about, or is it just a sort of a benign form of these disorders, then the SAA could be quite informative now. And we found that the SAA was positive sometimes when the DAT scan was negative, indicating that it could be an earlier readout for Parkinson risk than a abnormal DAT scan would be. So in these individuals, we might actually have a clinical utility sooner than among manifest Parkinson patients.
Yeah, I'm glad you said that. And that's also another common consultation that I get in my practice, and you probably as well, are patients with, maybe coming from sleep medicine with a new RBD diagnosis and wanting to know, what does this mean with regards to their risk for neurodegenerative disease? And maybe this does help stratify that risk or give us a little bit more information about the future. Andrew, I wanted to thank you and remind our listeners that I've been speaking with Andrew Siderowf from the University of Pennsylvania about his paper in Lancet Neurology titled Assessment of Heterogeneity Among Participants in the Parkinson's Progressive Markers Initiative Cohort using α-Synuclein Seed Amplification, a cross-sectional study. Andrew, thanks again for joining us today on the podcast.
You're welcome, Jeff. It's been a pleasure.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org /podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.